Welcome. Thank you, everybody, for joining us on the second episode of Lead with the Children, which is a Zoom recorded webinar produced by Fortify Children's Health. My name is Dr. Suzanne Brixey, and I will be your host today. I am a general pediatrician at General Booth Pediatrics in Virginia Beach as part of Children's Medical Group, but I am also the executive director of Fortify Children's Health. And I'm joined today by two wonderful experts, Drs. Jim Nataro and Doug Mitchell. Dr. Mitchell is a medical director of Children's Medical Group at the Children's Hospital of the King's Daughters, the director of International Adoption and Travel Medicine, as well as a pediatrician at Norfolk Pediatrics. And Dr. Jim Nataro is the chair of pediatrics at the University of Virginia and an infectious disease specialist. We are coming together today to really discuss the Children's Hospital Association's white paper, Matching Market Opportunities with Shared Strategies to Provide Pediatric Value-Based Care. So in the next 15 minutes, I'm really hoping to spend some time reviewing those foundational forces that are at work in the marketplace that are underlying the move towards value-based care. And because our guests have been a part of Fortify since its inception, I was hoping that we could spend some time recalling how these forces have been at play throughout the innovation of Fortify Children's Health. So this conversation is actually going to follow the format of the white paper that was put out by the Children's Hospital Association. You can find it on our website if you'd like to refer to it for further information. Specifically right now, though, to my guests, we're going to talk about the four main drivers of value-based care. And in this article, it really spoke a pretty meaningful quote from the CHA about the movement towards value-based care representing one of the most significant changes in the industry in a generation. So Dr. Nataro Mitchell, this is a really significant claim, and I was wondering if you could begin our conversation by responding to that.
Obviously, American healthcare is in an untenable situation as the cost of healthcare approaches 20% of GDP. This is clearly an unsustainable trajectory, and those of us who have spent their lives in healthcare, more recently in healthcare leadership, understand that there needs to be a fundamental shift in really the efficiency, right? That we want to be able to continue to deliver the same quality that we always have, but do it at a cost that is affordable to society and affordable to individual people, as individuals bear more and more of the cost of their individual health care. Doug?
Yeah, I agree. And at the same time of making it more affordable for everything, our real challenge too is increasing the quality, making sure we're providing real quality in what we do at the same time as decreasing those costs to the system and to the individual.
I would agree. I think reminding everyone about what that definition of value-based care really is, because we have value in the context of a quotient, right? We have quality over cost. And in a clinically integrated network, that's really what we're trying to do, is bring together and group together clinicians who are really dedicated to providing great quality for their children in a manner that is maintaining and managing that tremendous exponentially increasing cost, is what Dr. Nataro just mentioned. Any examples of what you see for value in the marketplace currently for Virginia?
Well, I think the values that we have to come up with is that as Virginia has increased the availability of Medicaid, expanded the Medicaid populations, putting greater demands on the state and on the individuals to provide care to more people, so we have fewer uninsured people. We need to continue to provide and increase that quality of care that we're providing to all of those people.
Yeah, I would agree, and to bring it maybe a little bit more concrete, you know, if you think about individual episodes of care, if an individual is free to go anywhere for care, they'll often go to an emergency room, or they may go to some other, they may go to a subspecialist, they may go to a high-cost provider. The very simple act of assuring that a patient and a family have a primary caregiver, they have a medical home to whom they can go for for trivial or moderate problems, to avoid emergency room visits or expensive subspecialty visits, et cetera. Just matching a patient and matching a family to a consistent primary caregiver is a very, very important cost efficiency strategy.
I would agree. And I think it's especially challenging in light of the current conditions in Virginia. We know we're having increasing volumes of children on the Medicaid, given the increasing burdens of the current pandemic and the children that are being funneled into Medicaid, and making sure that we're providing that medical home for those children, that they have those needed services, so that they have value added services to their care is so critically important. I think one of the things that the Children's Hospital Association's paper focused on are sort of 4 drivers to sort of the key value-based care. And I was wondering if the two of you could speak to some of those. And we talk about the role of the clinicians, we talk about the role of the purchasers or the payers in that regard, of the consumers, the families themselves, and also the role of government in making that transition that is really unique to the individual region of which a clinically integrated network is a part.
Well, so I think the first thing that really underlies all discussions of cost is awareness of cost. As providers, we tend to make choices really without knowing the effect of those choices on the pocketbook. So increasing awareness of cost and being able to, apply some basic principles. Is the juice worth the squeeze, so to speak? Do you really need the most expensive test to rule something out? And appealing often to studies that demonstrate whether a particular approach is cost effective or not. From the provider standpoint is very important. And then, the providers themselves, of course, can pursue various strategies to make their cost more efficient, but they need to be incentivized to actually do that. And I think the movement to more cost-effective care is really finally beginning to do that in an effective way.
I definitely can see that. And I think there are definitely challenges within the current Virginia local context with the move of all of our children cared for under Medicaid are now in managed care organizations, and the same managed care organizations across the Commonwealth, which I think gives us an opportunity to really engage with those MCOs to provide unifying pediatric themes that we can help support and create synergy as they're moving towards that transition to risk. Dr. Mitchell, what about your view for the actual purchasers or the consumers and their role in this transition?
Well, as Dr. Nataro mentioned, having that primary care home where we can help provide the consistent care as general pediatricians and educate our patients and our families as purchasers as to the best places to go to get that easiest care is crucial in providing that consistency and decreasing cost by the education process we do every day in the offices.
I would agree. I think there's so much effort to make sure that we're providing the right care for the right patient at the right time, and where do they need to go to make sure that they're achieving their optimal health. And I also think as we explore that transition of risk, it's really about engaging the community and other people, not just the physician, not just the hospital, not just the specialty, but a community, a medical neighborhood of health that we can bring around that child to make sure that they can achieve their optimal health as we move forward. I think that's always a challenge when we talk about the progression to risk, right? We speak about that often of how comfortable both clinicians who feel like I have no control if my child is graduating from high school or is reading, but we do know those things truly impact their long-term ability to achieve optimal health as an adult. I think some of those challenges that we face currently, even along the lines of, say, the HPV vaccine, right? It's a critically important vaccine that we want to administer to our children, but the value of that is seen decades in the future when we're preventing those children from potentially receiving a cancer diagnosis. So that challenge of that progression is very challenging for pediatricians who are really focused on prevention. Thoughts about that?
Well, let me just pick up on that thought for a moment, Suzanne, because characteristically, I don't want to be critical, but I think we all know that Americans and American business and American healthcare providers and lots of organizations tend to focus on the immediate future, not the long-term future. And so what you actually have to do is you have to build in financial incentives to provide long-term benefit for individuals, right? So if you're a payer, you are going to pay for healthcare this year. A patient or family is paying for this year's healthcare. You may not pay for an episode of care that's 25 years into the future. So we do need to make sure that we reorient American healthcare to provide the greatest benefit for the greatest number of people for the longest period of time. And that's really a very, very important aspect of value-based care, is that we're removing some of the immediate benefit and the immediate focus in favor of long-term benefits to individuals and the population.
I would agree, Jim, and I think it does speak to how we integrate as a health system, how we provide comprehensive care. I think right now, many people would say we're leaving or expanding beyond our fee-for-service model, which really has limited integration. And in my experience, our next step is really upside risk strictly in a pay for performance. And in that type of arena, you typically are going to need just screening tools, data, sort of evaluation of, hey, who is in our ED? Were we utilizing the ED appropriately? What are we doing for repeat readmissions? What could we do in an ambulatory setting to help support families so they didn't need to bounce back in that regard? What are our initial assessments, but really one and done type of interventions? And then we see the transition to upside risk or sort of shared savings, where you need much more integration within a community, self-management plans, patient-centered goals, really med reconciliation, problemless reconciliation. How do we communicate as a medical community? And then the next step is we're going into shared savings with upside and downside risk, which really needs chronic care management, disease-specific assessments, transitional management, a much more robust care management services that we need to bring to bear to help children achieve their optimal health in that regard. Did you want to speak a little bit to that progression of that limited integration to full integration as we take these steps along an alternative payment methodology as we work towards value-based care?
I think this is as you've outlined, it's a progression. It's clear that we can't jump from our purely fee-for-service methodology now all the way to being fully at risk. We've got to build the culture. Dr. Nataro just alluded to building a culture of time that prevention today in pediatrics results in long-term benefits later as they're adults. But that same culture change of moving to assuming the risk and sharing the risk and everybody benefits in that way is a progression. And you've got to build a different infrastructure than we currently have to move along that progression that you outlined.
Yeah, and I like to use the analogy of auto repair, right? So if you bring your car into a auto repair shop, they only really make money if they find something wrong with the car, and the more they find wrong, the more money they make. But if your car has a really good warranty, then it's actually in the interest of the repair shop to keep your car healthy, keep it on the road, right? The more they find wrong with it, the more they have to pay because they're sharing the risk. And that's the direction the American healthcare system has to go. We have to be incentivized to keep the patient well. And really the only truly effective incentive is if the provider or the provider's organization shares some of that risk of the care. And then there's really a very, very strong incentive to assure that you stay well rather than trying to fix you when you become sick.
I think that's right on point, Jim. And so one of probably the big question that I'm faced with Executive Director, and I'm sure the two of you as chairs for the Board of Managers for Fortify also face, is how would you envision that Fortify Children's Health, the Virginia Commonwealth's first pediatric clinically integrated network, will actually achieve shared savings? How does that happen for the network? How do we envision that that would be the case? And I think tapping into your analogy there, so much of what I see is our ability to integrate and align and create synergy around our care management services and a broad spectrum is really the key to that success. How have the two of you responded to that question?
But to me, it's all about gaining that knowledge and the data, partnering. Our role as pediatricians and Fortify is we partner with our patients and with our families, but we also need to partner with the MCOs, the insurance payers. And we're sort of that middleman of getting everybody together by increasing the data, having a better understanding of our determinants of health, understanding the challenges of the health that we provide, and bringing all those in a truly data-based approach to improving the care and in decreasing the cost. I think we're missing a lot of that. And Fortify has already come a long way in helping provide us a better understanding of those pieces of data to make better decision points for our patients and for the long-term financial benefits of society. So it's moving that along is the power that we've got in Fortify. And to do that, then, once you understand the data, you get a better job of managing the care, particularly for those with long-term chronic care conditions. You actually understand their risk factors and where their high costs are coming from, and how can you intervene to provide that better care at a lower cost.
I would agree. I think the data is tremendous. Go ahead, Jim.
No, yeah, I also wanted to agree. I think Doug just hit the nail right on the head. So, you know, American healthcare system transplants hearts, transplant livers, transplants kidneys on a daily basis. This should not be as hard as solid organ transplantation, right? And so, you know, so much of healthcare inefficiency lies in the gaps. You know, American healthcare system is like a series of islands. You know, you go from one specialist to another, or one institution to another. There's flawed communication. There's often bad follow-up. Patients aren't adherent to medications. They don't fill prescriptions. And simply having good care coordination, where you make sure that somebody gets from one island to another, or God forbid you provide multiple episodes of care on a single island, that tremendously increases the efficiency. And the other thing to underscore what Doug said about the data is that we know that a disproportionate amount of the cost is incurred by a relatively small portion of the population. But so imagine if you really knew every one of those patients who was a high consumer of cost, and you could direct your resources toward those high consumers. It would provide a much more efficient and frankly more intelligent system of care.
Right. I think that is so key of having the data. And I think that's really what Fortify has really tried to bring together, is that we actually know who is this population of children that we're trying to care for. Who are these children? Where are they seeking services? How are they seeking services? How are they engaging with the health system? And then, as you can see on this graph here, it really talks about once we know those children, as we progress from the fee for service to pay for performance, as you're moving up that curve, upside risk savings, we as a network need to build that capacity and that capability to understand more. Who are those children at risk? How can we tap into them? What services can we provide so that we can provide that support? And I think it's very challenging as a clinically integrated network to dive into a shared savings upside and especially a downside risk contract if you don't have that data, if you don't know what are the costs, what are our utilization methods, where can we intervene in a way that's beneficial for the health systems, for the physicians, and for the families. And sometimes that's a challenging balance to sort of create, but we all want optimal health for those children. And I think irrespective of the pace of the financial appetite or the market appetite for financial risk, irrespective of that pace, if you build that care management services and that care management capacity, you will be effective as a network no matter where we fall on that curve. You know, I know this is a graph that I really believe in, and I share in front of every single board meeting when I come to all of you to sort of remind where we sit and what we are trying to create, so that no matter how Virginia Medicaid or commercial payers transition into risk, Fortify is there to provide those resources, to provide that support, so we don't fall into that danger zone where we're contracting for something we don't have the capacity or capabilities to support. Any thoughts on that?
And you know, for the first time in looking at this, that as you mentioned, has shown us multiple times, it occurs to me too that market appetite financial risk is different for us as pediatricians than it is for the payers. The slope is hugely different. And getting everybody on the same page comes from that better understanding of the data. So we can come to common mutual understanding of what the slope of that curve should be based upon the data we have available.
And I do think that's what's unique in pediatrics, right? I think in the adult market where we have ACOs, which is typically based on Medicare, they're about 10 years farther along, right? For pediatrics, which are typically state-based because of the Medicaid financing of how the insurance for those children works, typically it's fits and starts, it moves, it doesn't. And I think pediatric clinically integrated networks across the nation have become quite adept about adapting to those fits and starts. You need to read the market appetite in your current state, in your current region, and respond. We still need to have a network of pediatricians that are coming together to build that synergy to ensure that the quality of the care for that child is upheld. So we need to have groups of networks of pediatricians coming together to make sure that those clinical care quality guidelines, method, all those truly enhance and improve the care of the children that we serve. Jim, any thoughts there?
Yeah, and yeah, so I'm going to continue on the thread, and you know, if you're listening to this broadcast, you may be excited and perhaps a little bit nervous about risk. I mean, risk is exactly that kind of word. It's exciting, but it's also sort of, it makes you nervous. And so, but only by embracing risk can we really make the kind of quantum jumps in the quality and efficiency of care that our children and their families and our society deserve. And yeah, it's a little bit scary, but two things are maybe three are very, very strong on our side, right? The first is that we are moving slowly towards this. We're not jumping into a high risk environment right away. We are really learning our market, our business, so to speak. A second is this is not the first CIN in the country, and so we've learned tremendously the lessons from other CINs and other ACOs, and we've even brought people in from those entities to talk to us and help to advise us. And then the last thing is the early on, the amount of risk that we're taking is not huge, it's not overwhelming. So I think what we're preserving is we're preserving the excitement of the opportunity, the excitement of the moment, without exposing ourselves or our CIN or any of the partners to excessive risk.
I think that is so important. The pacing is how we move forward, because we are successful together, right? Our clinically integrated network is successful when our hospitals succeed, our providers succeed, our clinical care teams succeed. We must be successful together to support the health of children. That is ultimately our guide. And we want to make sure that we are progressing in a manner that allows everybody to move forward as we embrace this new transition. I do think it is a vision of what impacts health. And in a way, as we talk about learning more about that population, I think we speak to how important it is to think about paying to care for the group. So back to your car warranty analogy, right? I think groups, regions, small as they are, that are in a full capitation model right now, have actually weathered the COVID pandemic extraordinarily well, because they were paid in advance to manage a care for children, to receive dollars to help support that full comprehensive network. This region's not there yet, but it does give us models to learn from as health pandemics advance and the next concerns move forward, that we would have resources and capacity to help care for the population of children that we serve.
As Jim was describing too, both as a leader of this organization and leader of our practice, I still see patients every day. And the excitement I see in this is the data I have, I've never had before. What's available to me in providing that care, of recognizing at a glimpse what I need to do to provide better care for that child that day, that minute, and then being able to conglomerate that information to better understand the entire population. I've never seen it before. And so it's exciting to be part of this project, this growing organization, to be able to make true day-to-day changes in how we provide that care to children is exciting to be part of.
I think the registries are phenomenal in ability to bring forth care. I think it's a great fear of physicians when you talk about value, that low utilization equals low value. And we're not striving for low utilization. We're striving for great value care. And the registries, I think, provide that. When you see a child and you can identify, this child has sickle cell, this child has Down syndrome, this child has these conditions, diabetes, and you can see right there, their last hemoglobin A1C was done on this date, or this child's in need of a transcranial Doppler, or this child is in need of a routine TSH because it has been beyond 12 months since they last had one. Those pieces of information at your fingertips are critical for helping us drive the correct utilization to the hospitals, to the sources, to make sure that we're being effective and efficient in what is best high quality evidence-informed care for these children.
Yeah, and remember also that what every primary caregiver needs on a daily basis is real effective partnership with subspecialists, right? So you need the subspecialist. When you need the subspecialist, you need really good care, and you need good communication and seamless interface. And Fortify really helps to do that, and the registries and the data that we have help to do that. And I talk to the subspecialists every day, and they are really delighted to have these registries. And, you know, remember, the subspecialists also are seeking an ideal and highly productive partnership with primary care. So it's really great to see those relationships really solidified with this effort.
I agree. Any other final comments as we close?
I have one last one, and that is that I don't think we can close without recognizing the tremendous power of the synergy between the two founding partners, Children's Hospital of King's Daughters and the UVA Health System. We have, I know we on the UVA side have learned tremendously from our partnership with CHKD. I hope and expect that you all have also, but having that Commonwealth-wide reach and having these two long-standing centers of excellence, I think has just been a remarkable synergy for us.
I would absolutely second those remarks, Jim. It's been quite a privilege and an honor to work so closely with UVA and with you and your colleagues. It's been quite a learning experience for us at CHKD, and the power that both of our organizations bring to make these changes cannot be denied. It's been quite a pleasure.
Well, it's been an honor for me to have both of you here, and it's definitely been an honor to serve as the Executive Director for Fortify Children's Health. I think bringing together the University of Virginia, Children's Hospital of the King's Daughters, in addition to all the employed and independent physicians, pediatricians, family medicine doctors, our clinical care teams who all come together with the goal of improving the health of children across the Commonwealth. It's a privilege to be a part of it. So thank you so much for spending your time with us today. We greatly appreciate it. I hope you learned something, and please know that the white paper that we discussed from the Children's Hospital Association is on the Fortify Children's Health website. Thank you.